Good afternoon, everyone. Thank you for joining us today. Happy almost end of 2021, and thank you for those that are joining us, whether this is your first or your sixth, for our six-pack series. Today's topic is going to be about end of life and hospice. We've got a great group of people on with us, so we're going to do introductions in a second. But thank you for that are joining us that are on Zoom, and thank you for those joining us on Facebook live as well. So we are going to be moderating all the comments or monitoring them and passing them on to the panelists. So please, if you have any questions or questions, maybe not answers, probably questions, please type those into the Q&A box at the bottom of your screen. If you are on Facebook, please type them into the comments there, and then we'll get those asked over to the panelists as well. For those of you on the call today, your lines are muted and we cannot see your faces. So your cameras are off, so we cannot see you or hear you. So those Q&A box is going to be the best way to ask questions. And we're not ignoring you if you're trying to chime in and ask us something. It's just that simply your lines are muted and your cameras are off. So we're going to do quick introductions and then we'll get started. My name again is Kim Brakke, and I'm the Sales and PR Director, or Sales and PR Regional Person for Region 1 in South Dakota. I'm based out of snowy Pierce, South Dakota, and I'm going to let everybody else go through and introduce themselves as well.
Hello, everyone. My name is Tammy Theurer, and I'm an RN. I'm the administrator for Home Health and Hospice CaringEdge, and we're located here in the Bismarck-Mandan, North Dakota area.
Hi, I'm Brendan Weidler. I too am an RN, and I'm the Regional Vice President for CaringEdge Healthcare in North Dakota and Minnesota, and I'm located in Bismarck as well.
Hello, my name is Natalie McCleary. I live in Moorhead, and I'm here to cover my experience with hospice for my father.
Hi, and I'm Deb Brakke, related to Kim. She's my daughter-in-law, and we're happy that we live in the same snowy Pierre community. And I'm here as a family member to share my story as far as my mom receiving hospice services.
Thank you all panelists for being on, and again, thanks for everybody that's joining us. Today's session is a hard one. End of life and hospice in this time of year is a really hard time to talk about it. But when we put this session together with all the sessions on the six-pack, we really want to talk about not just light and fluffy things. We want to talk about some hard stuff too. And so today is really going to dive in and talk a little bit about some misconceptions with hospice. What is hospice? And Natalie and Deb are also going to share their family experiences, as they both mentioned, and hope that those are helpful for you that are on the session today, that you can hear their stories, maybe relate a little bit, or maybe through their personal experiences that'll help answer some of your questions as well. So we're going to start with Tammy. If you just want to take it away and just give us some general information about hospice.
Thanks, Kim. And good afternoon, everyone. I'm so happy that you've joined us. As Kim mentioned, this is a difficult topic to talk about, but I think it's an important one, and one that sometimes, because it's difficult to talk about, might get overlooked. So I want to start with talking a little bit about what hospice is. When I read definitions of hospice, or I think of my own experience leading a hospice team is one of the first words that comes to mind, as well as expert care. There are other teams in healthcare, but our hospice team, I feel, brings expert medical care related to end-of-life issues. And so that team is broad-based. We have physicians and nurses who are more apt to address things like how they are doing an assessment. What are the changes that we're seeing? Are there any issues with comfort or symptoms that need to be managed, like pain or shortness of breath or anxiety, restlessness, that type of thing. And then we have hospice certified aides who are there to take care of people who need some assistance with personal care and hygiene, as well as provide companionship. And so besides that, then we have a social worker on every hospice team who addresses the psychosocial needs of not only the individual who's dealing with a life-limiting diagnosis on hospice, but also help the family to get through that experience as well. And then we have a chaplain or counselor on a hospice team who deals with spiritual issues at end of life. Again, that can be helpful for the individual who's going through that, as well as their family and caregivers. And then hospice is unique in that we have a volunteer program. And so our volunteers, unfortunately, in this pandemic, have been a little bit more limited on what they've been able to do. But typically, they're able to provide either care in the home, companionship, respite care types of things, or maybe they're helping with other special events and projects and so forth. Less often, we might see the involvement of therapy. So physical therapy and occupational therapists can be on the hospice team as well. What they provide is a little bit different than rehab. What we typically think of therapy, but they would help with also symptom management, maybe some ultrasound treatment to help a pain in a shoulder, that type of thing. Or an occupational therapist can help teach a family caregiver how to provide care and how to help move their loved one. Many family caregivers don't have that background, so it can be helpful to have an occupational therapist come and give them some tips. So typically hospice is provided in the home. And when we say home, it's a very broad definition of home. Home is wherever the individual defines it as. That might be the home where they've lived with their spouse for the last 50 years and raised their family. It might be their retirement community, a condo or an apartment that they're living in. Maybe they're living at their daughter's house. It might be that they're living in an assisted living community such as Edgewood or others. So wherever that is, I've been involved in hospice a long time, and I remember sending our team out to an RV park. So wherever home is where hospice can meet you. The hospice benefit not only provides those team members, but it also provides things like medications, medical supplies, and equipment that is helpful for end-of-life care. It's related to that or provides comfort measures. So things like pain medication or medication for shortness of breath or oxygen therapy, a hospital bed or wheelchair, those types of things are all covered under the Medicare hospice benefit. The other thing that I think is probably not talked about as often is that hospice programs provide bereavement services. And so there's a bereavement coordinator who works with the family after the individual has died and meets them where they want, provides the services that they feel would be helpful to them. That might be information that's mailed to them. It might be phone calls, it might be visits, it might be a support group for grief management, all kinds of things. So we plan for that care, and it's also individualized and unique. Hospice is about comfort. We're not seeking a cure, but we want to make sure that people are comfortable and that they have a high quality of life as long as they live. So we tailor that so that it's individualized for that patient and their family, and so they can get what they want out of it. So it's all individualized. We also are there to be supportive and also teach people what to expect. The topic of death in our culture is often not talked about real often, and so it can be difficult, and it's unusual. It's not unusual to wonder, well, what happens now? What do I watch for? What's going to happen to me or to my loved one? And so the hospice team can provide information about that, and very detailed information about what to expect as individuals go through that dying process. I want to point out that hospice is an entitled benefit under Medicare. People work their whole adult lives and they pay into those programs. And so when they're eligible to receive hospice benefits, they really deserve to have access to them. And so when I talk about eligible, it's really for Medicare, quite simple. Medicare can get complicated, but it's not too complicated under hospice. We look at basically two things. A physician has determined that they have a life-limiting diagnosis. So if the disease progresses, what would be a normal trajectory or process, then they would anticipate that they would have 6 months or less to live. And the other thing is the individual themselves has decided they no longer want to seek a cure for their disease. So they no longer want to get that chemo for their cancer, or they don't want to see their cardiac specialist or other specialist anymore. They're tired of going to the ER or being in the hospital. Those are all signs that maybe comfort care versus curative care would be appropriate. And so we want to provide that for them. Now, under Medicare, the hospice benefit is something that people elect. They volunteer, they want to have this service. So doing that, then they're not going to the hospital, they're not seeing all those specialists. So some of that traditional things that Medicare would cover is not covered, but they are getting the hospice benefit instead. But because they can elect it, they also have the opportunity to revoke the benefit. If something comes up, there's a new treatment, or they want to go to the hospital for some reason, they can very simply revoke the hospice benefit and go back to their traditional Medicare. Now, I mentioned earlier eligibility criteria. If a disease typically has a life expectancy of 6 months or less, I do want to be clear that the hospice benefit is not limited to that 6 months. In fact, Medicare has it divided up into benefit periods. There are 2 90-day benefit periods, 1 and 2, that gets you to the 6-month mark. But after that, there are an unlimited number of 60-day benefit periods too. So maybe people get to the point where maybe they are doing better and they graduate from hospice. But if they're not and they continue to meet the eligibility criteria, they can continue on through that unlimited number of 60-day benefit periods as well. Now, not everyone is on for 6 months period of time. In fact, one kind of startling statistic for me is nationally, when we look at this, 40% of individuals who go on hospice are on hospice for 14 days or less. So the benefit is for, at least 6 months, perhaps longer, but most people, or 40% of people, are on for a matter of days or weeks. That's heartbreaking to me, because I think there's so many positive things with the hospice benefit that I feel people might miss out on because it's on such a short period of time. But needless to say, then they still get the benefit, and we want to provide that. So it's an underutilized benefit, and so hopefully programs like this can get the word out a little bit more. Typically, we're not on a lot of billboards or a lot of big, beautiful buildings that say hospice in them, especially in the more rural communities. I live in Bismarck, North Dakota, and when I checked last, North Dakota is even lower utilization than much of the rest of the country. We're ranked 49th. So that's pretty low. And I would really like to see that the word get out there. So I appreciate the opportunity to talk today and hopefully get this information out that will be helpful to others who are listening.
Thank you so much for all that information, Tammy. I think that's helpful to talk about underutilization and the definition of it. Again, I know it's a hard topic to talk about. We'll say that probably a few times today. I know a question that's come up before is, what's the difference between palliative care and hospice? Is it the same thing? Can you maybe talk a little bit about that?
Sure. They are related. And so sometimes the terms are used interchangeably, but there are some subtle differences. So hospice is specific to a life expectancy of 6 months or less and not pursuing a curative treatment anymore. Palliative care is broader than that. It's for serious medical conditions, but there's no life expectancy limits on it. There is also, you can continue to seek curative care and still be under a palliative care program. In fact, the sooner you can get on palliative care, the better as well, because that's also a team approach method in most palliative care programs. And they can provide a lot of support and information and kind of navigating the medical system and deciding, yes, I want to pursue this, or maybe when is the point that it's futile and I should look at something else, such as hospice. I like to say that all hospice is palliative in that we are taking care of symptom management and trying to keep people comfortable. But palliative care is broader on the continuum.
That's helpful. So if a person were to, really this signing up for hospice comes from the doctor. So, but if a doctor says, yeah, no, your loved one doesn't qualify for hospice, maybe then the conversation, what would you recommend under those circumstances, looking at if palliative care would be the right step then if hospice isn't a factor?
Yeah, if there is a palliative care program in the community, they're not everywhere and they're not reimbursed in the same way that hospice is. So that impacts whether or not, often they're in larger communities, and most hospital systems have palliative care programs that I'm aware of. So I would ask about that and get involved there, and then proceed along that route. And then if hospice becomes appropriate at some point, then it's easy to slide into that as well.
Okay, thank you. We'll talk more about hospice in a bit, but I think we're going to shift gears now to Natalie, and we're going to let Natalie share a little bit about her family's and her experience with hospice. And Natalie, just whatever you want to tell us, I think would be helpful.
All right. Thank you for having me. I think my story has some significance to the idea of hospice. Also listening to Tammy, I feel my experience with hospice was very short. And when she talked about the 40%, I thought that's a lot of people that have hospice for 14 days or less. The background with my parents are, they have been in independent living at Edgewood Vista for 11 years. And Dad was diagnosed with dementia just a couple years ago. It came to the point that it was suggested by the staff and the nurses at Edgewood that Dad had gotten to be too much for Mother to handle, his daily living needs and so forth, that we should maybe look into moving him to memory care. So on February 19th, we moved Dad into memory care. The same time we moved Mom from a 2-bedroom to a 1-bedroom, still in independent living. And the setup was ideal. Mom was in the same building. She could just walk down and be with him. He struggled, of course. He missed her and he couldn't understand. Shortly after he was in there, about 2 weeks later, it was suggested that we go with a hospice doctor. When I was called and asked if that would be something that we could look at, I thought, my dad is healthy, he is not dying, when I heard hospice. And it scared me, but I said, yes, we'll meet with the hospice doctor. it was all wrong thinking that. When we met with the hospice doctor, she certainly was there just to keep Dad comfortable. Some of the medications he was on, he didn't need any longer. And some just needed to be adjusted. And the best part of it was I never needed to take Dad out of Edgewood again for a doctor appointment. They came into him. So the start of hospice with that was amazing, and it really, really helped us. Mom and I visited Dad several times a day, and with his meltdowns and so forth, they just called Mom, and she was able to run down and try to calm him down. And if not, then I would run and try to help him. And then we had COVID hit, and me and my husband were with Dad and Mom in Dad's room. We were watching TV, Mass. And after that, we went and we brought Dad to the lunchroom, and someone, the staff at Edgewood, came up to us and said, due to COVID, Edgewood is shutting down all visitors. And I just thought, what? I can't see my dad anymore? Well, it was both my parents, it was the whole community. So and then also in the time that they said that, they also said, and you must leave right away. So we said our goodbyes and left, and that was in March. And I felt horrible at the time because it was a lot of stress on my mother to deal with Dad's dementia alone without me. She really didn't understand, what he was actually going through. So I did the window experience for a while and to visit him, and it just confused him even more. It made him have nightmares about people coming, and so that didn't work anymore. So I just kind of went without seeing him and just went with what Mom told me. Then on May 11th, we got the call that he tested positive in the nursing home. After COVID came about, hearing about a gentleman that I knew at Riverview that had passed and was left alone and did not have family with him. And I promised myself that that would not be the case of my dad if it got to that point. So then on May 14th, Mom was also not allowed to visit with him anymore. And I was devastated. I thought, oh boy, how rotten is that going to be? So after that time, we were set up with hospice. It was suggested by Leona, the RN at Memory Care, that we visit with hospice. And again, I thought, not my father. I said, what is this COVID doing? So we met Bobby and on the phone, and Dad's health was failing quickly. And it was the infection in his lungs due to the COVID. And I worked very close with Bobby, and she was actually my communication in to express what was going on to me as I was out. And she was absolutely amazing. And to this day, I wonder where I would have been without the hospice team and doing everything. And then I decided after an email from her that I didn't really understand his condition and where he was at. So I said, can you please just express everything? She wrote me an email this long explaining everything, whether it was something I wanted to hear or not, but it was just something we needed to be ready for. And she explained it as gently as she could. So after visiting with her for a couple days, I also had this misconception that hospice was 24/7. And I thought she was sitting with my dad the whole time or along with another team member. And then I realized that wasn't the case, but she certainly was there anytime I needed to talk to her. If I'd email, she'd answer immediately. So to me, she was like she was there 24/7. And I just realized it was the time for me to be there at Dad's window. So I positioned myself one Saturday morning and I could see him breathing. And that's all I wanted to do, was be there and watch him breathe. And Bobby would come in and out, and she would explain to me what was going on. But when you talk about hospice giving comfort, that's exactly what she did. She was there for everything. She would increase his morphine if she thought he was agitated in any way. He was very, very peaceful. At the window, two ladies came up to me, and I was pretty excited because I thought, all I need is a chair to sit here, and I can be here for as long as I need to be. But they asked me if I wanted to go in, and I was shocked, and I immediately thanked God, because that was my promise to myself and to my dad, that he would not be alone. So I got all geared up with the PPE, and I saw my father face to face for the first time in several months. He didn't actually know me, but I know as we sat in his room, he would become startled, and then he'd open his eyes and look for me, and I would just assure him that I was still there. And Bobby would come in and her team quite often, and I would get the answers from her that I needed. The chaplain was also wonderful. I know my dad has a very strong faith and appreciated that. So I was there 5 days with Dad only. And on the morning that he passed, I remember Bobby and a team member coming in, and she knew that he was at his end just like I was. And I just thought he was uncomfortable in his bed. It really didn't make any difference because he was on morphine and they had kept him comfortable. But I just said, can you reposition him in the bed? And I thought, she's going to say, oh, it doesn't matter, don't worry about it. She went and got a pillowcase with her team member, very gently went and put it underneath my father and positioned him better on the bed. Whether he knew it was better, or what, but I did. And again, she was there not only to comfort my father, but me also. It was very hard being alone with him at the end. And he passed that afternoon, and Bobby came in immediately. She made all the calls that needed to be done. She called the funeral home, and she sat there with me for a long time, and we prayed, and then she asked if she wanted me to stay there. And I thought, no, I think I just need the time alone. And she left, and she arranged everything, and the funeral home came, and that was it. And I haven't seen her after that, though I wrote a little note and thanked her, and I miss her, and I pray she continues to do the work she does, because I only had her for 5 days, but she was amazing. And the whole hospice thing. She was proactive in everything. And within those 5 days, everything was, I think we should get ready for oxygen, and I think we should do this. And never did he have to suffer. I mean, she was just proactive and always there for him. And then after Dad left, Mother still receives calls and mail, like Tammy said, on bereavement. And I appreciate that so much too for my mom. So that's my story.
Thank you, Natalie. There was no questions that came in as you're talking. There was one comment from Patty saying hugs to Natalie. I was looking for Kleenex around my desk because I couldn't find it. I don't have any. I didn't plan ahead. I just think from the bottom of my heart, and I'm going to speak for maybe everybody and they can chime in too, but sharing that, I think losing someone is never easy. Losing someone during COVID, unfortunately, all of us on this call, I think can say that we've lost somebody or we've known of a friend who's lost somebody. Anyways, I just mean, it's not easy to lose somebody during COVID. And I think you sharing your story helps people realize they're not alone. They're not unique in their situation. I don't have any other questions for you, but I really just want to say thank you for sharing your story because I think it is helpful, and I'm sorry for your loss, and I'm glad that hospice was able to comfort you in those. I just feel like you would have had a very different story had you not had hospice, and I'm glad that you did. That's my point there. And yeah,
Absolutely. Thank you.
Okay, there is a couple things. Melinda came in and said, thank you for sharing such a difficult story. It's much appreciated and will help me in the coming months. So thank you, Melinda, for sharing that. And then Jean also wrote, thank you for sharing your experience. My sister survived COVID in a memory care facility. She's only 63. So I think just people can identify obviously with what you're saying. And so thank you. I'm going to turn it over to Brendan because I think Brendan might even have a question for you, but I know he's got some more to add a little bit too with hospice. Thank you, Natalie.
Thank you.
The one thing that that really struck me in listening to your story is a common thread that we see, and it goes towards the utilization of hospice in general, especially in the Midwest states, is the reluctance to even really look into hospice. And there's nothing wrong with that. We certainly as an organization want nothing more than to provide education as much as we can in the general public to, offer people an explanation of how wonderful this benefit is, especially when used appropriately and timely. And so I know that they maybe talk to you about hospice right away. And just because you only experienced it for 5 days, which is unfortunate, I don't want you to think certainly that feel guilty about only being able to experience it for 5 days, because sometimes we just don't know. And this COVID stuff has certainly created a lot of havoc in the hospice realm because you just don't know how people are going to react to it. And in a lot of cases, people do elect hospice if they meet criteria. And they want to use hospice at that point in time. Western medicine in general, very, very curative based. I was going to mention from earlier when we were talking about talking to your provider about hospice. Certainly something I would recommend speaking to your provider if you feel like maybe you could benefit from a hospice program. But in some cases, primary care providers maybe are a little bit reluctant when it comes to hospice, and maybe that has something to do with the training, the curative training that they've received, or maybe for religious beliefs or things of that nature. And so if ever you have questions about eligibility criteria or things like that, the professionals in hospice programs, in any of your local hospice programs, getting in touch with maybe a medical director or a nursing director or something of that nature could certainly help you, and they would be able to steer you in the right direction, whether you could or couldn't maybe meet those eligibility criteria. I did want to mention one thing. Thanks, Tammy, so much for your overview. You always do such a good job when explaining hospice to anybody. But one thing that you touched on that I wanted to also take a second to touch on is the medications, the equipment, and then the supplies. This is part of the hospice benefit, and to better explain that, it is paid for by the hospice benefit in most cases when you're on hospice. So anything that's related to your terminal diagnosis then would fall within that. So you wouldn't be paying for those things. And then I know Tammy touched on it again, but Also worth noting, as far as ER goes, oftentimes we do see people that want to look into hospice just because, they have a difficult time with symptom management because of some life-limiting disease, and they're frequently in the ER, and they just don't want to go to the ER anymore. We become your ER, and we're going to be with you on a more consistent basis to hopefully regulate those symptoms so you don't ever feel that you need an ER. Hopefully that we can provide you with measures and management opportunities to take care of some of those symptoms so that you don't feel that you need the ER. But that's the one piece that I wanted to add today. So I guess I believe we're going to go to Deb now. So thanks, Kim.
Could I just interject one thing, Kim, if I might? Because
Absolutely.
Natalie also said something that struck me is, I hear this a lot too, is I thought hospice was going to be there 24/7. And that's also, I think, a common misconception for people. We do have additional eyes and ears in the home because we have a nurse in there and a social worker, a chaplain, perhaps an aide, maybe volunteers at some point. So there are a lot more people coming into the home, but we do come and go. The nurse might be there once or twice a week, the social worker once a month. It all kind of depends on what the needs are, but we don't move in. We're part of the team that's taking care of the individual. So that might be the Edgewood staff in your situation. It might be family, caregivers, if they're in their own home and that type of thing too. So I'm glad you pointed that out, Natalie, because I think that is something that is not well understood. So thanks for providing that.
Thank you again, Natalie, for mentioning that and then for clarifying that, Tammy. I think that's helpful just to walk through what it is and what it isn't, just because hospice, I think, is so emotional too, that there's a lot of that behind it that sometimes people don't always, if they go into something thinking it's something, not that their perception can't change. And I think it can still obviously be a great benefit to them, but it's helpful for them to understand what it will be and what it won't be. Deb introduced herself at the beginning. She's my mother-in-law, but I'm going to let her share her story now because hers is different than Natalie's. And I think it's worth kind of hearing another hospice story. And so Deb, I'm going to let you just share your story and hospice for our family.
Okay, thanks, Kim. And Natalie touched my heart more than I expected. So I'll try to go on. Right now, today I'm here to talk with you about my mother, who is almost 86 years old. She has been living independently, not at an Edgewood facility, but in a senior living apartment complex that has really no medical services provided. She has a history of chronic obstructive pulmonary disease. She also has a defibrillator due to a cardiac issue, obviously. And she has a history of breast cancer and colon cancer. So she, everybody says she's a tough lady, and she is. She's got an attitude. So I guess, thank God for the attitude, even though it's kind of trying. And she also has dementia that does impair her cognitive decision-making, but still is at the point where she is able to make medical decisions with input. And that's a day-to-day challenge as well. So anyway, in August this year, I took her to her regular 6-month checkup with her oncologist. She had colon cancer several years ago and had surgery followed by chemotherapy. And so this was the normal routine follow-up. And we expected that was her last visit. And then we were going to go out and have Bloody Marys or something because she'd been feeling well, and we just thought this was over. However, the reports from the CAT scan showed that she had a tumor in her left lung, and she, with her history of the COPD, was already on oxygen 24/7 she has been for about 2 years. So it wasn't a surprise that there was a tumor, but they'd been watching it and it had grown. And then there were 2 other spots on her left lung as well that were new. So at that point, the oncologist indicated she needed to have a biopsy to determine what type of cancer so that he could proceed with the appropriate treatment of chemo or radiation or.
Deb, I think did you get muted
She said,
somehow?
I can't.
Okay, your sound is
Oh.
back. I lost your sound for a second. You're still there. I think you're good.
Okay.
You're going. You're
Okay.
good.
All right. Well, and I might have drifted off into a softer voice too. So anyway, my mother, while hearing this from the oncologist, said, I can't do chemotherapy again. And I don't want radiation. She said, I'm old, I'm ready to die, that sort of thing. And my sister and I were there with her at that appointment. And we both said, you need to think about this. This is a big decision, and let's see your primary care physician. And she didn't realize she had another doctor at that point. So anyway, over the course of about 10 days, she did see her primary care physician who knew her history well. And he also said, the risk benefit of treatment is up to you, but it would be a tough road. So anyway, she accepted that she was at the end of life or moving that way quicker than we thought. And the oncologist did the referral for hospice services. At the time, I felt like, oh, this is way too soon, Natalie. So I really relate to your feeling that your dad was pretty healthy overall, so maybe those medical experts have a unique perspective. But anyway, I kind of felt it was too soon, and I have a healthcare background, so I thought I knew a lot about hospice and have a lot of friends who work in hospice. But I was kind of surprised because I actually felt like hospice in a way meant we were giving up on mom. And I was shocked that I felt that way, knowing that it's all about comfort and care, not giving up. But anyway, I didn't want her to feel that anyone was giving up on her either. And she's never verbalized that at all, that, she wants to go back for treatment or whatever. So anyway, in about a 2-week time frame, back in August, all of those things happened, and the hospice nurse came to mom's apartment, and I was there for that first meeting. And actually there was a hospice director who had come prior to the nurse coming. So they did their intakes and assessments and introductions and explanations. And it was really a comfort to my mother. And it was a comfort for me, even though I thought, oh, I kind of know all this process. But it was a great comfort to my mother and a validation that she had made the right decision for her. So anyway, since August, mom has been getting weekly RN visits, usually an hour or so. And I'm not there for all those visits. I've been there a couple times, but I wanted to make sure they have their special relationship without my presence. So the nurse does all the physical assessments. She checks mom's oxygen levels and makes sure mom's oxygen machines, as she calls them, because she's got a stationary and then she's got a portable. So she's checking all of that. She manages mom's medications and sets them up every week. Makes sure there's refills if they're needed. Checks her blood pressure, recommended an inhaler for my mom, and that's been beneficial. And she does a lot to reduce my mother's anxiety because I think it's a part of the dementia process that she gets very anxious. And in fact, she was averaging a couple of ER visits a year prior to receiving hospice services. I think mainly because she would wake up in the night and be so anxious and afraid, she would pull the emergency cord in her apartment, and that triggered an ambulance that transported her to the ER, where she would have constipation, was she would say is her reason for being there. But anyway, just to reemphasize what Tammy was saying, that once you as a patient are receiving hospice services, ER visits are really pretty much inappropriate. And so that's been a relief for us. And even my mom has accepted that, no, she doesn't need to go to the emergency room. She can call the hospice number on her refrigerator, and there's always someone on call, and they will take care of her. So it's been very reassuring, even though most of the time she doesn't think she has the phone number, but she eventually finds it. So anyway, recently she was up to 2 visits a week because of different things happening with her. She hasn't had any hospice aides coming in, but that service is available should she want that or need that. And she has a social worker and a chaplain who also come to see her once a month. It's really sad because of COVID that volunteers cannot come in and visit with her, because with restrictions on visitors overall, she is lonely. And she, I guess we all digress or deteriorate a little bit without some social stimulation. And with the restricted visiting, even family, we're not going as frequently as we would without COVID. So it's too bad that we can't have the hospice volunteers, because she would enjoy that, and it would overall really make her days much brighter. So anyway, my takeaways are, I'm very thankful that we have the hospice services, and that it was a very early referral. My father-in-law was in long-term care, and he was referred to hospice for about, I think about 3 weeks before he passed away in April. And that was a very important part of his end-of-life care, mainly for the family, because they basically were our lifeline and communicated with us as to how he was doing. And no one in the family got to see their dad or husband the last 6 weeks of his life. So Natalie, you were lucky. I'm glad you were with your dad. Excuse me. So anyway, hospice is a great service. The emotional support, another pair of eyes and ears to assess and evaluate and offer encouragement. And I think at some point with my mother's dementia, she may have to move to a different type of environment to keep her safe. And so I'm very glad that we have hospice who can help us go down that road when the time comes, because my mother's attitude will be another challenge, and having hospice professionals there to help us address what happens next will be very reassuring for all of us.
Thank you, Deb. I know for being in the family with grandma. It's I know there's been comfort and help it, as you guys have been out of town for medical appointments or any travel to see grandchildren other than not my kids, but it's helpful to have that hospice nurse there, so it's not always falling on your shoulders. I know that that's something that we try to jump in and help, but I think as the grandchildren of a grandparent on hospice, it is, I know there's comfort in that it's not just falling only on family all the time, that there's medical professionals that are at our fingertips that utilize and can help give her comfort and some stability when then it's not just all in family. So.
Right. And I would like to add to that, the communication between hospice staff and family is open, and we can call and talk with her nurse. She has one particular nurse that most often sees her, and others that address on-call issues, but it's open communication. So if we have a concern, if I have a question, or if I want to let the nurse know that, mom had a bad episode of whatever, I call, and it's a two-way communication. Jen gets back to me if she's seen something that she feels I maybe have missed or that I need to be aware of, or if she has a question that my mom can't answer. So it's a wonderful service. It's not particularly a 24/7 per se, but the comfort is 24/7, even though there's not a physical presence at that level.
That's a good way of putting it. I know there's a question that came up when you were talking, and I don't know if this will be more of a question maybe for Brendan or Tammy, but it says, are there accommodations if a memory care loved one suffers and doctor says it's failure to thrive? So I think maybe Patty's asking is, I don't know if that means, is hospice appropriate if there's failure to thrive? I don't know, Tammy, you've unmuted, so maybe you can answer that.
Medicare doesn't like the diagnosis of failure to thrive anymore, but typically there are other diagnoses. Alzheimer's or other dementias are life limiting. They are going to progress and be terminal. And so I would recommend reaching out to the local hospice and having them take a look at the medical record, because chances are they'll be able to find a diagnosis that will work and probably be very appropriate for hospice services.
Thank you, Tammy, for addressing that. One other question, I guess this kind of leads to what Deb was saying, that grandma started hospice in August. What happens at the end of that 6 months? Brendan or Tammy, can one of you guys address what that looks like for somebody who, because I know I had a grandpa who was on hospice 2 times, and he then still at the end of 2 6-month sessions was still alive and lived for 2 more years beyond that. So what does it look like towards the end of the 6 months, or what happens?
What happens then is the hospice team will do, they'll put together all of their assessments, and then the medical director or a nurse practitioner, some provider that works for the hospice company, will do an actual face-to-face visit and look and see, okay, do we still think this is a life expectancy of 6 months or less? So the 6 month is, it starts again. And so if they feel that, gosh, I don't know, I think they're doing so well, maybe they would graduate from hospice. And then, like you said, be able to come back on at a later date. But chances are too that there maybe is something there that's showing maybe they're sleeping more, or maybe they've fallen, or maybe there's weight loss, something to indicate that there is a physical decline. And they've got all kinds of tools to help measure that. So the providers and the hospice team will be able to answer that as they go towards then what would be the 3rd benefit period if they renew hospice. Does that help?
Yeah. Brendan, I think you had something that you wanted to add as well.
I was going to mention too that yes, we're looking at that after the first 2 benefit periods. But one other benefit that we see on hospice programs is every 2 weeks or sooner. We have an interdisciplinary team meeting that discusses the patients that we have on service. And so we have all of the team members in a room together, coming up with any strategies or bringing forth any concerns, whether it be symptom management, or maybe it's something to help family with grief or whatever it may be. We're meeting at least every 2 weeks on each individual patient that we have to discuss this, and also looking at whether or not disease progression is continuing to make them a hospice candidate.
Okay, thank you. I do have another question that came in, and this one is more on the medication side of it. Jean is wondering, and I don't know on Jean's side if her sister is actually on hospice or not, but she said, my sister's on Aricept and Namenda. Would you recommend these be discontinued, as I don't see these are needed at this middle stages of Alzheimer's? So I'm not clear on that question if she's actually on hospice or not, but if somebody is on hospice, Aricept, Namenda, have you guys, Tammy and Brendan, had any experience with medications and being discontinued? Oh, she's not on hospice though, is what Jean said.
If someone is on hospice, then that would be part of that conversation that we'd be having on, is there a benefit to the medication? Are there side effects that maybe are troublesome? But we always involve either the individual themselves, if they're able to make their own decisions, and or their family caregivers in that too. Some people, we might think, well, this isn't appropriate anymore. They don't really need this anymore. But, when you think about, oh man, I've been on this blood thinner a long time, I want to keep taking that, we want to get their input too. So medications like are mentioned, yes, we would look at those on whether they're beneficial or not, get involved, the medical director involved in that conversation with the family and the patient to help make that decision together.
Thank you. That's a good information. I think we have time for one last question that came in. I think this is a really good one. Rosemary writes that if a person with dementia recently put on hospice, then develops a UTI, for comfort, can the person receive an oral liquid antibiotic if they are taking food and fluids? This would be meant for comfort to minimize other meds for comfort that could cause increased cognitive symptoms they're not aware of their surroundings, such as family. So anyways, basically, if somebody gets a UTI and they're on hospice, can they receive treatment for that?
Absolutely, because it, like was mentioned, it is a comfort measure. The other thing I would add to that is typically I wouldn't put someone through the rigor of getting a urine sample for that. If they're symptomatic and they've had UTIs before and this is what it looks like, then let's just start an antibiotic. They don't need to go through that pain of getting a urine sample and getting it tested and all of that. We can go ahead and treat the symptoms with an antibiotic.
Thank you. I think that's helpful, just to kind of walk through that. Brendan, did you have anything else to add regarding that question? Nope.
Nope, that was exactly what I was going to mention, is
Okay.
Diagnostic testing oftentimes in some capacity goes to the wayside, especially if the medical director feels comfortable in providing that script. So.
Well, we are at the end of our time today. I want to, though, quickly give Brendan, Tammy, Natalie, Deb, the opportunities. Is there any final thoughts that any of you guys want to end with today? If any of you guys have anything that you'd like to add in, I just want to give you this time right now.
I would like to comment that listening to Natalie and Deb's stories, although there were vast differences in their experiences, there were a lot of similarities as well. And I just want people to know that there's no one way to do this. It's all individualized. There's no right way or wrong way for end-of-life care. It's a difficult decision, and I commend you and thank you for sharing those stories. But that's what struck me is that.
Thank you, Tammy.
I guess I'd like to add that I really appreciate and thank people that are in this kind of healthcare and understand where my dad was and made these suggestions to me. I would have never known to not be with his primary doctor anymore and have a hospice doctor come in. I would have never known to get hospice when he was at the end of his days. So, you know, I think these healthcare providers, they need to continue to, you know, talk to us and make suggestions, because without Leona, I would have never known that I needed this as much as I did.
That's good, good information. And I'll make sure we pass that on to Leona too, because that makes a difference. And I think that those healthcare providers need to hear that. I think that makes a difference to them to hear that they did something, especially right now with COVID. It's trying times that are draining on healthcare workers. So we'll make sure Leona gets that message. It's recorded, so she can even watch this and hear it from you directly.
Yes, she knows.
Brendan or Deb, I don't know if you guys have anything else to add.
Well, just one thing that was part of the education process for our family is even though mom's on hospice, she got her flu shot, she is expecting to get the COVID vaccination, and she has had a UTI, of course, on a weekend. So we had all the on-call and everything worked great. So that was treated. So it is really all about comfort. And it's not that, okay, now you're in a certain category and we just sit and let nature take its course. So I really appreciate Tammy's explanations today to make that clear to hopefully everyone who's listening today.
Thank you, Deb.
I would just add that please reach out, ask questions. If you want information on hospice, but you're not in an area which CaringEdge or Edgewood Healthcare provides hospice, don't let that be a barrier to giving us a call. We'll certainly advocate for you and for your loved one if you believe they would benefit from hospice. But certainly there should be a local provider that you could reach out to in any market. So, and thanks for having us, Kim. Appreciate it.
Yeah, thank you. That's how I wanted to end to thank all of you. I know this was a hard one. I think everybody had tears on there. I had a few texts from people that were crying that said, oh my gosh. And so I think this was powerful. Thank you, Brendan, Tammy, Natalie, Deb, for all being on, for sharing your story, sharing your expertise. Again, it was a hard one, but thank you for letting us do this. For those of you joining us today, thank you for joining us. Today's session's recorded and will be available. So say you watch this today, it was helpful, you think my sister needs to watch this, my brother, whoever, we'll have this available. We have a great YouTube page where we have been storing these and they're available as a resource. So you can always send an email to info@edgewoodhealthcare.com. If you're already registered for the session, you will get an email with the link. But if you are not registered and you're happening just to catch us on Facebook today, email that info@edgewoodhealthcare.com and we can get you the link for today's session so you can always watch it later on. Jean says, thanks for this opportunity. Thank you, Jean, for joining us. But this is the end. This is our last of our 6-pack series. It's not the end of all of our virtual education, though. We have things planned for 2021. No dates or topics to announce today, but just stay tuned. And again, if you've signed up for the series, you'll hear about those. But that info@edgewoodhealthcare.com. If you're ever interested in future stuff, you can always email us on that and we can get you signed up to be in the know about future educational offerings. 2021, I hope will bring us back together in person so we can see one another. But I think we've learned that in 2020, this is a great avenue to reach people that maybe live remotely or they don't want to drive with the weather, different things like that. So I think we'll continue this as well. So thank you all for joining us today. Thank you, panelists, and have a happy, healthy end of your 2020. And we look forward to seeing you in 2021. Thanks, everyone.